Hello, Claire. How are you?
Hey, I'm good. How are you? How's Portland? Is it cold?
It is a little cold. We had that's so weird that you asked that because I've been really actively pondering this recently because it feels like a proper spring in a way that I can't remember having in a long time. I must have in Boston, right? But I think maybe, 1 year recently we went to Oregon for February to March. So it's the first time it feels like for me in a while that I've had a proper spring where it's 40s at night, 60s and the flowers are blooming and I'm really liking it. I like sort of this proper middle, but we are not having sort of what I know my friend in DC and in New Jersey, I think my parents were saying that it's 90 last week at some point. I don't know if you have a similar thing.
Yeah, it's this false summer. It's really confusing. And I think what's happening here is not great. A lot of animals are coming out, the toads, the frogs, the whatever, and the flowers are blooming and then it'll freeze. And right now it's 50 degrees and quite cold here. I'm freezing. We had to turn our heat back on. So it's been a bit of a whiplash and I don't like it.
Yeah. That's what's weird is we had some warmth, but that's what I mean. I think actually is we are having some flowers bloom, but I get the sense that we're not going to maybe we'll have one frozen night or a couple frozen nights, but looking at the weather report, I'm okay, it seems fine-ish. So maybe, but I want to talk to you later, not on the podcast because it is the wrong topic, but I really want to talk to you about if you ever track amphibian migration because I just learned about that and I feel like that's something that would be up your alley.
Oh yeah, we can talk about that. You know me.
Just to give a little bit of editorial gossip or editorial, what did Paul call it last week? Newsroom gossip. Last week was really interesting because me, Paul, and Claire, Sarah was at a conference and me, Paul, and Claire all had sort of just fall into our laps almost really stories that were very in our wheelhouse, each of us. So that was a really just on, again, that sort of background gossipy editorial planning side of things. It was a really cool week in that way because, we were all just following our passions. So Claire had sort of this HPV story, this public health story, this, more featurey story where she talked to a patient. And again, not going to give too many spoilers, but I had a story about just a super nerdy pancreatic cancer sort of milestone. It was the first time that a phase 3 trial of a RAS inhibitor in pancreatic cancer specifically had read out. And that alone probably would have been a story, at least it definitely would have been covered by us. But what made it even better was that it had really, really great results. So it's reportedly the first time a drug has shown a greater than 1 year survival in metastatic pancreatic cancer. It doubled the OS, the median OS of the results of the trial. Results were that the drug doubled median OS from 6 months ish to 13.2, I think. Don't quote me on that. Look in the story, but yeah, that was just a really exciting story and got it to look into molecular stuff, how it worked. RAS was infamously called the undruggable target for a long time. So I got to just sort of nerd out about that for a while. And then Paul wrote an incredibly very policy heavy story, sort of zooming out, abstract, what is the future of oncology as a whole, really big picture stuff. So, and sort of, working with the cancer center leaders and all of his networking, that's his favorite thing to do. So I feel we all just got what we wanted. If there was more than 24 hours in the day, would have been an ideal week.
Right, seriously.
So yeah, and we had a guest editorial by John Stanford of Incubate, talking about the most favored nation drug pricing. And then we had a sponsored article, and cancer policy was pretty dense as well. There's stereotactic breast biopsy needles are on the shortage list, FDA shortage list, as well as some other kind of nuanced things. Friends of Cancer Research had a meeting on external control arms, etc. So definitely peruse at your leisure. So yeah, that's sort of my that's my job is the headlines. But I'll pop it over to Claire to sort of run through what our plan is. We have a little bit of a weird podcast plan, so I will let Claire discuss.
Sure. Well, I'll just briefly introduce my story so there's some context for what happens next. The newsy bit is that FDA has approved the first at-home self-collection kit for HPV. And this is something that advocates, cancer prevention folks have been pushing for about 2 decades. It grew out of this NCI-led public-private partnership where basically FDA needed to see that unsupervised collection and clinician-based collection were clinically equivalent. So that was the final data that was needed. So this kit now kind of paves the way for more of this, and it's a big deal in terms of health equity, especially for numerous reasons. You know, there are lots of people who avoid getting a pap smear, whether it's because of access to the space, medical trauma, sexual trauma, the list goes on. And the population that ends up dying from cervical cancer, which is highly preventable, are these populations that have kind of historically fallen through the cracks of the healthcare system. So this kind of levels the playing field. The one patient that I spoke with, or not patient, but a user of a self-collection kit on one of the mobile Game Changer buses in Boca Raton, Florida, run by Sylvester, described the experience as just empowering, and she felt like it was so easy. She couldn't believe how easy it was. It was just, it felt safe. It felt quick. Just kind of a very different set of vocabulary words than you would ever use to describe a speculum-based exam in, your OBGYN. So exciting. As many of my sources said, like anyone who's had a speculum-based exam would never be like, that was fun. Let's do it again. It's not fun. So it's kind of opening up this new category of care in the cancer prevention space and at large. So all that said, a piece of this story that was so interesting to me, but just ultimately didn't make it into the final piece, was Dr. Otis Brawley talking about the evolution of pap smears, the history of cervical cancer screening, which is more in depth than I expected. And so I wanted to include some of that storytelling from his perspective because he does it so well. So we're going to pop it over to Otis to tell us more about the history of pap smears.
The history of cervical cancer screening is actually quite instructive of a lot of things in cancer. It's important to remember that Dr. Papanikolai, who was at New York Hospital in New York, he was a Cornell physician. Dr. Papanikolai developed the pap smear in the 1930s and 40s, and he became a huge advocate of the pap smear. He got the American Cancer Society, who was already into early detection regarding breast and colon cancer, become an early advocate for the pap smear. And by the way, in the 1930s, cervical cancer was a bigger killer of women than breast cancer. I don't know if that was true in the 40s or not. We can check. But in the 30s, it definitely was. The American Cancer Society in the late 40s and early 50s began a series of what were called demonstration projects, where they encouraged use of the pap smear. Now, what ultimately happened was they demonstrated that nobody knew how to read cytology. Indeed, cytology was not a specialty of pathology at that time. There were a whole bunch of pap smears that were misread by pathologists who didn't know how to read pathology. And that led to some people getting unnecessary treatment at the time. Unnecessary treatment can involve hysterectomy, it can involve conization of the cervix, where a large part of the end of the cervix is cut out. When that happens, a woman can end up with cervical incompetence if she gets pregnant, meaning the baby will fall out. Sometimes we have to do what's called a cervical cerclage, which is like a purse string stitching of suture around the cervix to literally tie the baby in. Eventually we got our act straight, and it took throughout the 1930s 50s and 60s for cytology to become a recognized subspecialty of pathology, and people got better at reading cytology. We ended up with cytotechnicians, because you can imagine it's really boring to sit there and have to read 80 pap smears a day under a microscope, and very few doctors were willing to do that. And so we ended up training cytotechnicians to do it.
Okay.
Then there was this incredible push towards screening for cervical cancer in the 1960s and 70s. The American Cancer Society literally had commercials about it. It was actually the first time that they were allowed to say the word cancer on television.
So then, in the 1980s, Harold Zerhausen figured out that cervical cancer was caused by the human papillomavirus, and in 2008 was awarded the Nobel Prize in Physiology or Medicine for his discovery. And then throughout 1930 and onward, there's this literature about how cervical cancer must be a sexually transmitted disease. Some of that data was as simple as nuns never got it unless they were bad girls before they went to the convent, and prostitutes very commonly did get it. And then second wives that came after women who died of cervical cancer very often got cervical cancer. So there was always speculation. Could it be gonorrhea? Could it be chlamydia? Could it be the herpes virus? And finally, Zerhausen settled it. And about that time, people started speculating that there was some dysplasia that did not progress to cervical cancer.
And there are these pictures that people have drawn where you can go from normal cervical epithelium toward dysplastic epithelium toward more dysplastic epithelium. We actually called it CIN1, CIN2, CIN3. As the number goes up, it gets more dysplastic, or it looks more unlike normal tissue. Is a good phrase for dysplasia, a good definition of dysplasia. Then you go from CIN3 to carcinoma in situ, which looks like cancer, but it's not invasive yet. And then you go on to invasive cancer. In the 80s and 90s, we started realizing that some of these things would go to CIN2 and then regress back to normal, or even sometimes go to CIN3 and regress back to normal. And most of the ones that went to CIN1 regress back to normal. And so in the 1990s, the National Cancer Institute did a series of clinical studies, huge, large trials, and those trials actually demonstrated that a large number of women who had cervical dysplasia, CIN1 and 2 especially, could be watched and did not need to be aggressively treated. Up until that point, some women got hysterectomy because of CIN1 or 2. More commonly, they got laser ablation of their cervix, or they got cauterization of their cervix, or they got freezing of their cervix, or they got a conization, and a lot of that treatment was unnecessary. All right, and there was this sort of come to Jesus moment in the late 1990s when the gynecologic community actually realized that for several decades they had been over-treating cervical cancer.
So it's kind of like what happened with mammography, too.
Yeah. Actually, in the 1970s, late 70s, early 80s, there was an American Cancer Society demonstration project on breast cancer. They call these things demonstration projects, interestingly. And they found out that a large number of pathologists couldn't read needle biopsies. And as a result, there were some women who ended up getting mastectomies that didn't need mastectomies.
Devastating.
And so, anyway, we've gotten better since the 1990s. there's a bunch of women who have cervical dysplasia who get watch and wait, and so it has improved. The self HPV testing is a tremendous improvement, especially amongst women who don't want a pap smear or don't want a pelvic examination. I don't need to tell you how invasive it is. And we've actually started learning that it's certain types of HPV that are more likely to regress versus others. And then, of course, the vaccines came along and became available 20 years ago, and we've gotten better with them. You know, the initial vaccine was just for type 16 and 18. Then there was the quadrivalent vaccine, which was good for 16, 18, and two other types of HPV. And now there's a 9-valent vaccine out there.
So that was Otis Brawley. So interesting. And I know that just to sort of connect what he said with something that we've been talking about, Claire, and we've been trying to kind of stay up to date on, is sort of this change in how many shots, the HPV vaccine, and the change in scheduling potentially and data on that. I am clearly not up to date on it.
Yeah.
So I'm going to ask you to
Right. So this didn't make it into the story, but, you know, the HPV vaccine, Gardasil, has been around for a while. And there is now talk of this one-shot vaccine. It's not been approved yet, but this Gardasil one-shot, a single-dose regimen for HPV. And some studies and international bodies like WHO support single-dose effectiveness. Globally, it's really important. Because access to the vaccine remains limited. So fewer than 30% of adolescent girls worldwide have been vaccinated for HPV, and a single dose regimen would be easier for people to get. And World Health Organization has recommended that since 2022. Until now, no study had directly assessed whether a single dose regimen would provide protection comparable to that of 2 doses. So stay tuned. But I think one thing, just a bit of a zoom out to, and this is more of, maybe US focal conversation, but, you know, misconceptions about HPV and myths about HPV have really prevailed. And I've learned more about this since joining the Cancer Letter. Just last year, there was a survey that showed that most Americans don't really understand that HPV leads to cancer and that the HPV vaccine prevents many of those cancers. Electra Pasquette speaks about this a lot. She's in my story. And she talks a lot about how we need to kind of rebrand the HPV vaccine and kind of re-emphasize that this vaccine is a cancer prevention vaccine. Yeah. It literally prevents these cancers. Back in the 90s, maybe earlier than that. But I remember it was just kind of talked about as this like green light for promiscuity, right? It's not what it is. That's just not a fact. But we are also meeting this moment with another moment where people at the top, our HHS secretary is a bit of a vaccine skeptic, not a bit, but a vaccine skeptic, and so it's coming to a head, this conversation, I think, and then we have cancer vaccine space is opening up in other ways and therapeutic ways. So I imagine this to be an ongoing conversation.
Something really stuck with me about that story that I just maybe is a cool thing to wrap up on, and what you're related to what you're talking about. And I want to try to find the actual like exact words because I feel like they're important, but cervical cancer can be eliminated within our lifetime. That was really interesting to me because I am going to the gynecologist. And one of our coworkers were like, "No more scoot," and only like maybe half of our listeners are going to understand what that means, But it's like that is such a again, as a user of these technologies, it's a little bit of a different conversation than just in the abstract. Yeah. But even that, I still was so unaware of how, I thought it was oh, you must be able to get cervical cancer another way. And I'm sure that there are, again, nuances I'm not familiar with, but just how interlocked HPV and cervical cancer are, and how it's literally
99% of cervical cancers are preventable. Yeah, but together with cervical cancer screening, the HPV vaccine, and follow-up, multiple sources told me that cervical cancer can be eliminated within our lifetime, in theory.
So crazy. Yeah. So that's what this story is like, come on, let's cure cancer.
Oh, I was just saying, I mean, what other cancers are we talking about like that? You know, that just feels really poignant and something that needs to be said more than once and in many ways.
Yes, absolutely.
Yeah.
And especially considering like we're talking about this need of education and awareness being sort of this, or at least one of the missing links here. So we'll be shouting it. Yeah. But thank you so much, Claire. I guess we'll wrap up. And thank you, Otis, wherever you are,
Otis.
for talking to us. And I'm sure he'll be back on the podcast soon too. So see all the listeners next week.
Thanks.